Hi everyone. The topic for now is hypoglycemia in neonates. Hypoglycemia in neonates. Neonates are children born from the first hour to the first 28 days of life. In other words, low level of glucose in children under the age of 1 month. Let's go. What could cause low level of glucose? What could cause hypoglycemia in these cute human beings that have just come to this world? Okay, first thing is you take blood glucose level, but you should know the whole blood glucose is 15% less compared to the plasma value. I will make a separate presentation on details about all those things, but just know those who are taking the sample, where they are taking it from, and what they should expect. The higher the hematocrit, the lower the plasma and the lower the glucose level. Just to let you know, where you are taking the sample from is important. Low blood glucose is normal. Let me repeat. Low blood glucose is normal in neonates if it is transient. The English is clear. The newborn, the cute human beings, male and female, that have just come to this world, when you check their blood glucose few hours after, if it is low, that is fine, but it's expected to be built up immediately feeding is commenced. So why am I making this presentation then? It means there could be other situations where it will not be transient. In other words, it will be persistent. Okay? Low level because continuous supply via placenta from the mother is cut off. When the baby was in the womb, there will be supply from the mom to the baby through the placenta. But remember, at delivery room, the father will be invited in and be given the scissors, dress, gown, everything, and be asked to cut the cord. Once that is done, hello, the supply of glucose to your baby is cut off. Now, the baby is having inconsistent supply while on earth here. Can't judge by the value in the first 2 to 4 hours. We can't make pronouncement that this is hypoglycemia or hyperglycemia in the first 2 to 4 hours. It's going to be difficult. Then it will start building up once that baby is being fed. We are expecting something to happen endogenously, and that is glycogen should be broken down after birth. What has been stored while the baby was in the womb, the glycogen that is stored is expected to be broken down to meet the requirement before being fed or before the food fed is passing through the entire processes of digestion and absorption. Then the level of insulin is expected to drop, but the rate at which it drops will be considered in a bit. So, if the hypoglycemia is not corrected within hours as stated above, we will have persistent hypoglycemia. That is the problem. It should be transient, and all these normal processes would have taken place within the body itself without, too much exogenous intervention or introduction of anything except for the normal feed. Now, why? Why can any little newborn have persistent hypoglycemia? One, prematurity. When this pregnancy has not been carried to term, not yet 37 weeks or even 36 weeks plus, we are fine. maybe delivered at between 32 and 36, that could lead to inadequate glycogen storage. They're not old enough, they've not saved enough money. The higher the gestational age, the higher the glycogen stored. Okay? It's like the older you become, the more the money you could save in the bank. But that's not true anyway. There's so many young people could be rich, and so many elderly are rich as well. Okay. Counter-regulatory hormones inefficiency. It is expected when the glucose level is down, the counter-regulatory hormones should come into action. But when they are inefficient, when glucagon and epinephrine are not generating enough glucose, then the level of the glucose will remain low. Intrauterine growth restriction. In those days, we call it intrauterine growth retardation. The smaller they are, the smaller the level of glycogen stored. And of course, by the time we then need that glycogen to be broken down to form glucose, either gluconeogenesis or glycogenolysis, what are we going to get? We don't get much. Why? You've not saved money in the bank. Now you're financially hard up. What's going to happen? You can answer that. Insulin increase in infants of gestational diabetic mother. There we go. This is a serious issue. The placenta transfer of high glucose to the fetus has led to very high insulin production in the fetus. The woman has been diagnosed with gestational diabetes mellitus. The glucose level is very high, and that will pass through the placenta to the unborn baby. And while there in the womb, the level of glucose will stimulate the beta cells of the pancreas to start producing insulin. So the insulin in this baby is high. But once the placenta is cut off, the level of insulin will not drop immediately. Get it right. The insulin level is high because the glucose transferred to the baby in utero is high. But the cord has been given to the father. The excited father has cut the cord, and everybody, yay, congratulations. Everybody's smiling, but the baby starts suffering. Why? The insulin is still high, and it's not going to drop immediately. Meanwhile, the supply of glucose has been cut off instantly. So the level of glucose has ceased, and at a zero supply, for some hours, when those good, and kind-hearted people will be dressing the baby, cleaning and warming and wrapping up, the insulin level is still high. So there will be imbalance between the glucose level and insulin level. And of course, when that is the situation, in this case, the insulin will have the upper hand, shutting down the glucose the more. That's why they always suffer very low level of glucose, severe hypoglycemia in infants of gestational diabetic mother. Causes of hypoglycemia could also be as a result of sepsis, as infection in this woman while pregnant, and is transferred to this young man or lady. Liver failure. While liver can't handle the glycogen, can't store enough, the liver is not working well. Hypothyroidism. We need growth hormone and all these hormones for action. Growth hormone deficiency, cortisol deficiency, they all shoot glucose up. Hypothermia, mothers meds like insulin and sulfonylureas now have an effect of bringing the glucose down in the child while in the womb, but the effect has continued while the child is there. Neonatal polycythemia will lead to high hematocrit, low plasma, and low glucose. What are the clinical features? Yeah, most time it is asymptomatic. Why? Because while you are still dressing the baby, wrapping the baby up, warming the baby up, and within few hours you start putting the baby on the mother to suck the breast, or you give artificial feed or whatever, you might not know, because even when the symptoms are there, you will think it's something else, maybe they are cold or whatever, because the first set of symptoms are called adrenergic symptoms. The baby will be shaking, having tremor, could be pale, could be breathing very fast, sweating profusely, and irritable. But many people could attribute this to something else. So, unless the glucose level is checked, they may never know until they are fed and everything is over. But it could be worse in some, and they go to the next stage of symptoms called neuroglycopenic symptoms. And at that stage, they'll start having poor sucking reflex and poor sucking activities. They won't be able to suck the breast from the mother, and even when given the artificial feed, it will be very slow. And it means when they couldn't suck well, then feeding is impaired as well. Hypothermia, could have seizures, they become weak, very tired, lethargic. It can go into coma and actually die. Also, there could be hypothermia, apnea, and cyanosis. The diagnosis is simple. Just do glucose for all newborn and all children on admission. Risk factors. I've just mentioned a while ago that babies of gestational diabetic mothers suffer a lot. I'm not go over that again. You can just back up a bit and get that information again. Prematurity, like I've said, prematurity is responsible for that. I've explained that. Big babies or large for gestational age, like we will find in babies of gestational diabetic mothers, or those are just like that, not even because the parents or the mother has diabetes, but they are big, and once the cord is cut off, they have the problem. Intrauterine growth restricted babies, I've explained that. Preeclampsia or eclampsia in the mother. We will have a separate presentation on preeclampsia and eclampsia, so I will not dwell too much on that right now. Cleft lip and palate, because the feeding pattern might be a bit difficult. Beck-Willingham syndrome, mother of insulin, on insulin or sulfonylureas, polycythemia in infant with high hematocrit, low plasma, low glucose, asphyxia or ischemia, total parenteral nutrition. What are the possible differential diagnoses here? Sepsis, hyponatremia, neonatal encephalopathy with asphyxia, particularly when there is neuroglycopenic symptoms. How do we handle this? We put D10 up at 2 mils per kilogram per minute. Then follow that up with 6 mils per kilogram per minute of the same D10. And of course, we'll be checking our glucose periodically. Glucagon could be used if we don't have that available at 10 to 50 microgram per kilogram intravenously, or if you can get, most times we use umbilical cord, but if you can't get that, you go subcute or IM. cortisone 1 milligram per kilogram intravenously or per aura every 8 hours. Diazoxide, somatostatin. But if beta cell tumor is suspected and is identified, what are you going to do? You have no option than to invite the surgeon to take it out. Pancreatectomy at the early part of life. Dextrose gel with formula filled will save life. Complications. Generally, there will be increased neurodevelopmental impairment in any child with persistent hypoglycemia, like I've just said, neuroglycopenic symptoms and so on. So we are not going to joke with that. So if the child is not handled on time, it's possible this child could go into coma, and we are still delaying no action, or maybe it's not identified immediately, the child could die. So personal recommendation would be that any newborn baby under our care and with the history from the mother and the physical examination and the observation that this child is not going to be fed early or is being introduced with artificial milk, or the mom is lactating, which is not very common the first few hours of birth, well, do blood glucose level quickly, or just to save yourself, save the baby, save the parent, just do glucose level. Just know what it is. That is after 4 hours. You might not get the true picture the first 1 to 2 hours, no, but 4 hours and do glucose level. But while doing that, while cleaning, start feeding the baby anyway. Just do your best anyway. So it's easy to lose these wonderful human beings to hypoglycemia if we don't take the blood glucose on time and get the necessary help. So in conclusion, checking blood glucose in neonates could be life-saving. Could be. Those killed human beings need urgent attention. Thanks for listening to my presentation. Kindly subscribe so that you can be getting this immediately they're published. Thank you.